Thanks everybody again for being here. Yeah, I just wanted to chat really quickly about substance use disorder screening and assessment. It's not a very complicated tool, but it's a powerful thing that I think you can have in your arsenal when it comes to SUD treatment. So with that, we'll just jump in. I don't have any disclosures for today. Here are the objectives for today's talk. We have a few of them. The first is to appreciate the substance use epidemiology as it relates to substance use screening, review current SUD screening recommendations, realize the role of screening as it relates to SBIRT or brief intervention and referral to treatment, review SUD screening tools, and illustrate ways that you can implement substance use screening into your practice. So here's our roadmap on how we're going to get there today. So let's just jump in. Let's talk really quickly about substance use epidemiology. I think this is no surprise to this group here, but substance use leads to more death and disability than any other preventable condition that's out there currently. With alcohol really leading the charge here, alcohol is the third leading cause of preventable death in the United States. Opioid and other substance-related overdoses continue to climb, and it leads all-cause mortality in the group under age 50. So very significant to kind of identify patients with substance use, substance misuse, and substance use disorders. So the next few slides I'm going to share here are from something from SAMHSA, which is called the National Survey on Drug Use and Health, or the NSDA for short. In brief, this is an annual survey that's been conducted, I think, since the 70s, honestly, and includes patients or people that are over age 12 that are living in households. So just a quick note on that because it excludes unhoused individuals, people that are incarcerated or the military as well too. So these are housed people over age 12. But even with those limitations though, really it's one of the best tools we have for assessing kind of national drug use trends currently. And these are done every year. And this is the most up-to-date version of the slide. So this first slide is looking at past month alcohol use among people ages 12 and older. So you can see here kind of these concentric circles. And the first one shows that 134 people report using alcohol use, right? Within a subset of that, you can see about 60 million people report binge drinking. So just really quick, what is binge drinking defined as? In this definition, it's 5 or more drinks for men or 4 or more drinks for women at one occasion. And then about 14 and a half people have identified themselves as heavy alcohol users. So those are people who meet that binge drinking criteria that I just mentioned, but do it more frequently. Specifically for this data set, it's 5 or more days in the past 30 days. So you can see here that use does not necessarily correlate with any of these, but you can see these different subsets in between that. This next slide deck here is kind of looking at past year substance use among people, again, over age 12. You can see that about 74 million people actually report using substances. And of those substance uses, the 3 most prevalent are marijuana, hallucinogens, and prescriptive opioid use. This next slide, though, is kind of shifting just from use. Remember, so use does not equal substance use disorder, but these are patients that meet criteria for substance use disorder based on this tool, based on this survey. And of course, again, you have to meet the DSM-5 criteria in order to have a substance use disorder. So within this, survey, there are about almost 50 million people that have a diagnosed or suspected substance use disorder. And the important thing to note here is that these categories are not mutually exclusive either, right? So people with polysubstance use can fall into any or all of these categories as well. But you can see here that the top 3, and the drug use disorder is kind of like this all-encompassing term here, but kind of dismissing that, you can see the top 3 most prevalent are alcohol use disorder, marijuana use disorder, and opioid use disorder. So the top 3 here that are identified in the NSDA. And then this last slide here, I think, is really relevant to this group. So this is looking at people who get treatment that have, from those people that were identified as having substance disorder, that actually get treatment, right? And this is the crux of screening. Almost 41 million adults with substance use disorder did not receive treatment for substance use disorder when the survey was done. So there's definitely a gap here. And really, again, taken together, these slides highlight why screening is so important, right? First, you can identify people with risky use. So those are people without identified substance use disorders. So that way you can intervene early. But it also identifies those with substance use disorders as well too, right? And then you can connect them with treatment. And that's really a spirit of what screening and referral and assessment really is all about. And that's important, for us as healthcare providers because we have a lot of opportunity to intervene with folk. So this data set looking here is looking at, primary care visits and ED visits specifically. And a lot of people see us. A lot of people see healthcare professionals, right? So this slide showing that, 82% of adults and 92% of children see a healthcare professional. And about 55.5% of all the billion office visits that are done are from primary care. And there's 130 million ED visits annually. So there's a lot of opportunity to kind of screen people for substance use within that context. But why screen, right? Like, why should we be doing this? Again, we just talked about this high prevalence of substance use disorder in medical settings and opportunity to screen for those folks. But I can tell you this from personal experience too. A lot of times if we don't screen, we don't know. Whatever we don't screen for, we don't know, right? So there are many patients that don't disclose their substance use to their providers. And many healthcare providers are unaware of the patient's substance use, right? So by screening, we can help identify again and intervene early. But why else? Why else should we screen? Well, I think number one, it can help reduce use, right? Early intervention. And we'll talk a little bit about kind of what that referral to treatment and intervention can look like. But honestly, it also helps understand the patient's needs and how we can match the right services to the needs, right? And the additional thing is that interventions can also improve clinical care. So, what are some ways that we can do that? One, I mean, if we know somebody, for example, is having withdrawal, we can help treat that and prevent that. We can also look for medication interactions that may interact with their underlying substance use. It can also help us identify accurate diagnoses, right? So maybe somebody has resistant hypertension, and you're trying interventions for that, but they did not disclose, you did not identify the patient has an alcohol use disorder. So we're treating symptoms, we're not really treating the underlying cause there. So it can help with those things. It can also help improve treatment outcomes, right? So if patients tend to stick around longer, maybe they'll be more adherent to their medications. And it can help prevent harm, right? So we can help with, overdose education, harm reduction, those kinds of things. And if somebody has a substance use disorder, like opioid use disorder, you can start treatment. It really just helps us, tailor our medical management to the patients. The other thing it does is it has this unique ability to also reduce stigma in a way. So, with thoughtful implementation, and we'll talk about what that looks like here in a minute, we're really trying to normalize talking about substance use and screening for substance use. And with that, we kind of put it in the context of just typical overall health and medical care. And when we do that, it allows more opportunities to discuss these things and open up and have that dialogue with patients. And then, of course, just from what we saw here with the NSDA, it informs our population health and epidemiology, right? So what are the current trends? What's the prevalence of these things that's going on? And maybe it can help identify services that are needed for certain areas or interventions that can help out specific sites. So it's really important to help screen. All right. So some really quick points on screening recommendations. So what are the current screening recommendations? So the United States Preventative Task Force has been recommending that adults over 18, and that includes pregnant women, get screened for both drug use and alcohol use. And that is a grade B recommendation, right? And that's universal screening for everyone over 18. The caveat for this, though, that they recommend, and this important context here as well, is that drug use specifically should be screened for when there's services to actually help identify a diagnosis for the patient, provide effective treatment, and then refer them to appropriate care. But for this conversation here, this is pretty much true of all primary care ED settings too, right? You can make that diagnosis, you can refer them to treatment, and especially for these SUD specific folk that we're talking about today on this group, I think you should be screening universally for patients for substance use disorder. So what is the general kind of concept of screening? Like, what is the overview of that? So really the goal is to help identify risk. So, identify the risk and then provide targeted interventions based on that risk. That's really kind of just the overarching idea here. So for example, if you screen someone and they have low risk, they may not need any intervention or referral at all, right? So they're kind of okay where they're at. If somebody has a moderate risk, for example, they may need to have a brief intervention or referral to treatment on top of that. If they have a high risk, you may need to intervene quickly, right? So it allows you to risk stratify these folks and help identify next steps on how to treat them. Just a quick note on screening versus assessment. So I think this is an important kind of thing to tease away a little bit. So screening is just that, right? It's trying to identify risk. Whereas assessment is really about diagnosis, right? That's like an actual substance use disorder diagnosis. They're different things. Screening does not equal a diagnosis necessarily, but it helps identify patients who are at risk for a specific diagnosis like substance use disorder. So some other things to specifically note out of this as well is that screening occurs soon after somebody's in an ideal state, soon after somebody's seeking services. You want to filter their substance use disorders, mental health concerns, any other risks that may be pertinent. You can use it in a variety of settings, and really it can help tailor interventions based on what is found on that screen. And it assists in the referral to treatment. Those who, like I mentioned before, those who may screen positive may not necessarily need additional resources unless they're screened at a high risk. Whereas assessment typically occurs after screening, right? And it's really about gathering all the key pieces together about the patient's problem and developing a treatment plan. And mental health and substance use disorders are assessed in the context of each other to help rule out presence or absence of co-occurring disorders, determine the individual's readiness for change, identify strengths or problem areas that may reflect the processes of treatment and recovery, but really help to identify and develop an appropriate treatment relationship. So they're different things. Screening's more quick and assessed very rapidly, whereas an assessment takes time, diagnosing these things, gathering the information. It's just an important thing to remember when it comes to screening. And again, just to highlight here, use, just like we talked about with the NSDA, and we've highlighted here before on these talks, is that use of itself does not mean somebody has an addiction or a substance use disorder. They really lie upon a spectrum. But regardless, screening for any use can really help identify even low risk, risky use, or problematic use that may down the line, effervesce into a substance use disorder. So early intervention is really important with the screening tool here. Just a quick note on SBIRT, or screening, brief intervention, and referral to treatment. So these are just essentially a number for all the different pieces that are involved in there. So screening, we just talked about, right? Assessing risky substance use can occur in any healthcare setting. But what is brief intervention? Really, that's engaging a patient to show that risky substance use can really be worked on, right? Provide feedback on their current use and kind of intervene at that time. And then referral of treatment is exactly what it sounds, is kind of referring them to the appropriate level of care based on kind of their risk level. So just a little follow-up on brief intervention. Really, the thought of this is providing information and feedback about the screening results when you see them, understanding the patient's views on their use, and then coaching the patients to consider changing the perceptions about their use, really like motivational interviewing here, encouraging the patient to discuss their views, their likes and dislikes about use, and how they may consider changing, advising patients in a clear but respectful way to decrease or abstain from substance use, teaching behavior change skills that reduce substance use as well as the chances of negative consequences, and then establishing a follow-up method with the patient. And that may be done either in person or over the phone if needed, or via telehealth. And then referral to treatment should be done accordingly, like I said, on the ASAM continuum of care. So if somebody has a higher need, appropriately referring them to that higher level of care. Whereas if they fall into the more, probably common outpatient follow-up algorithm, referring them to that kind of pathway as well. All right, so we talked about, what's going on with the substance use epidemiology, why it's important, what the screening recommendations are, but really, what are the tools to help you get there? What are some of the screening tools that you could utilize in your clinic? I think one of the important notes to quickly jump into this, though, is urine toxicology actually a screening tool? And the short answer is no, right? So screening toxicology is really there just to detect recent use. It doesn't give you a history of their pattern of use or anything like that either. It's just one capsulated time moment that you get a clinical snapshot of the patient. And there can be false negatives and false positives either way on some of these tests too. They're not perfect. So We do not recommend routinely using screening urine toxicology as a screening tool when it comes to this. Instead, and this is just a kind of a window to show you what those timelines are. Dr. Work's great at the toxicology timelines for all these things, but in brief, they're only there for a brief moment in time and they don't give you the whole clinical picture. But really, a better way to do that is to use some validated screening tools. And an important concept to think about when it comes to tools is being mindful of your clinic environment, right? That's one thing we're going to talk a little bit about today, is that some of these tools are really quick and easy, and otherwise are very low resource intensive. And some of them take a little bit more time and they kind of scale up that high resource intensity pathway. The thing about when it comes to screening and implementing in your clinic is really determining what fits best for you and your operational workflow there, right? So logistically, who's going to do the screen? How much time does it take? Is it a nurse? Is it the provider? Is it somebody else who's involved in the whole healthcare team there that can help participate on this? But I think conceptually thinking about how long these things take and who's responsible for them is something I just want to plant the seed on as we work further. And also keeping in mind that the diagnosis part, like I mentioned earlier, is a different aspect of this, and that does take more time. You have to see the patient and kind of go through that whole process. So what are these validated instruments? There's a few, and there's many more beyond what we're going to talk about here today. These are just some of them. These are some of them that I know that are more routinely used, that are validated, meaning that they have evidence behind them, that they're replicable, that you can use. And I believe all of these are free to use as well too. So you don't have to pay any copyright tools or anything like that to utilize these tools. They're free from the services that made them. All right, so first is alcohol. So what are some common alcohol screening tools? The first is something called the SysQ-Alc. So what does SysQ stand for? It stands for single item screening question for alcohol. And it's just that. It's a single item. It's one item that you ask about, and it takes probably a minute or less to do. So very low resource intensive. It can be done by an interviewer, or it can be self-administered as well too. The next is the Audit C, which probably some of you are familiar with. This stands for the Alcohol Use Disorders Identification Test Consumption. That's 3 items. It takes a little bit longer, a couple more minutes, but also can be interviewer or self-administered. So what do those look like? So what is a SysQ alcohol? This is the question. How many times in the past year have you had 5 for men or 4 for women or more drinks in a day? Asking that question is a validated way to screen for alcohol use. And how is the test scored positive? Well, if there's any response more than 0, then it's a positive score, right? So that's a really quick and easy way to do that. What about the Audit C here? And I'm sorry, my apologies. It is really squished on here. So I'm going to walk through these. But the other thing I'm going to say really quick is that a lot of these tools that I'm going to show you here have corresponding web-based tool systems, meaning that if you scan the QR codes that are on the bottom or on the corner of each of these slide decks, you can actually pull up where to find these. So if you ever wanted to do this and it's not embedded into your electronic medical record, for example, you can just use MD-Calc or other options that are out there that I'll walk you through. And you can kind of just ask these questions and click these buttons and have it automatically score for you. So Audit C has 3 questions. How often did you have a drink containing alcohol in the past year? How many drinks containing alcohol did you have on a typical day when you were drinking in the past year? And how often did you have 6 or more drinks on one occasion in the past year? There are different scores here based on the level that they're doing, and they're kind of listed here. But based on the responses from the patient, you get a score, and the higher the score, again, like we mentioned earlier, the appropriate kind of referral treatment based on that level of risk. So higher score, more intensive, less score, less intensive. What about for substance use? So for other drugs, for example, not alcohol related, well, guess what? There's a SysQ drug as well too, which is also just one item, 1 minute, very easy to do. And then there's another one called the DAS-10, which is a little bit more comprehensive. It has 10 items and can take about 10 minutes to do if doing appropriately. Both of these can be done interviewer or self-administered as well. So what's the SysQ? SysQ is how many times in the past year have you used an illegal drug or use a prescription medication for non-medical reasons. These validated instruments were probably created before appropriate language. So this is not probably the language I would use, but this is the way that validated tool was verified. Let's just give you that background on it. Again, if somebody says, more than 0 on this SISQ substance, that's a score that's positive for this screener tool. The DAS-10, and for time's sake, I won't go through all of these, but there are 10 questions on here that are pretty comprehensive. This gives you a more detailed look into other substances beyond just opioids as well, too. So this is another way to look at other things as well. All right, so what are some ways you could do both? We talked about individual screening. What is one that does both? Now, one way you could do this operationally is to do either of those in combination. So you could do a SISQ and a SISQ alcohol, SISQ substance, or a DAS-10 and an audit C. Like that's one way to hit both. But there is another tool that does all of them in one, and that's called the TAPS tool. And it is pretty nifty. It does like an initial screener, which is called the TAPS 1. And based on that, it automatically escalates to a TAPS 2, which is a more comprehensive assessment if needed. The thing is, it can be comprehensive, so it can take a few minutes to do, depending on the patient's responses. So it can be anywhere from 4 items up to 25 items if everybody says yes to all the questions, and it can take anywhere from 2 minutes plus if the answers are appropriately answered yes. Again, this can be interview or self-administered. This is really nifty. I try to lean into this as much as I can personally at the clinic. Again, if you scan this and open it up on your web base, it's really nice. It even has the option here to click at the bottom. You can see where it says I am the patient or I am the clinician. So you can theoretically put this on a tablet, for example, give it to the patient, click the I am the patient button, and they'll just click through these boxes. And here for the clinician, you click the clinician and you click through the boxes. So really easy to help administer and utilize in your clinical setting. And then these are just some example questions of what that's going to look like. What's really nice about the TAPS though is it has very detailed like next steps based on the level of risk. So not just kind of what to do, but kind of the whole shebang, if you will, on what next steps should be for each of these screening tools. So it's pretty nice. And it also gives you a risk level for the specific substance use disorder. For example, in this case, I went through high risk questions for opioid use, and it says patients at high risk for opioid use disorder. Kind of gives you a red flag, if you will, for identifying patients. So taking a step back, what does that mean? Practically speaking, it means like if you want to do something really fast, really low effort, you can use those single item screenings or the TAPS kind of one questionnaire if you wanted to. A little bit higher resources would be the Audit C or DAS-10. And then of course, kind of implementing those into your clinical workflow is kind of the way to do it. Personally, if I had to take a stab at this, I would probably just do the TAPS one and see how you do because it does all substances, both alcohol and substance as well. And it scales it based on the responses from the patient. Might be an easy way to implement it at the clinic. Just a couple of notes for best practices on SUD screening. Always use validated screening tools. That way your assessments are replicable and validated. Really, when it comes to these tools, you want to communicate to the patient that the goal is to improve health. So really one way that's been recommended is to put up posters and say, hey, we screen for everybody, flyers about this to just kind of, again, normalize that we're screening. And make sure that you ensure privacy during screening. That can be, again, by having the patient self-administer it or do it in a private setting whenever you do these. This is protected health information. And tell the patients what you're going to do with this, right? So we're doing this screen because we want to identify and help you out if anything's found on these survey instruments. It kind of helps with better buy-in for the patient. Again, so use self-administered screening if possible. Like I mentioned, it's probably the easiest way to do, and it's a lot more private. But if not possible, try to think about your existing workflows and ensure privacy. Another way to normalize it is to put it into other screeners that you may do. So if you're doing PHQ-9, looking for depression, for example, or other social determinant of health screening questionnaires, you can incorporate that and really do it with the healthcare provider. It really helps kind of set the tone that this is a medical thing that we're doing. All right, so we're getting close to the end here. We talked about the tools. So how can you do this at your clinic? This is a really nifty tool as well, too. If you scan this, this is from NIDA, the National Institute on Drug Abuse, as part of one of their CTN dissemination tools. Really, what's cool about this is you go through this walkthrough and you say, I work in a primary care setting, or I work in an ED setting, or I work in a substance use setting. You specifically say where you're at, what kind of resources are available. Do you have nursing? Do you not? Kind of what's available at your clinic. And this will tailor kind of based on what's available to you, an appropriate way to screen for patients. So it's a really nice way to help you operationalize this at your clinic locally. This is a quick scan again for SBIRT, what that is and what those components are if you want to implement SBIRT into your clinic. And then a quick update on SBIRT as well too. You can actually get reimbursed from this. So if you are a private practice clinician and you're looking to, operationalize this and say, do I have the time to do these kinds of things? There is a reimbursement rate for doing the screening as well too. And these are the different rates there. So there is an added benefit of doing the screening as well from an economic standpoint to help make sure, and they do this to help make sure that we do this because it's an important thing that we do. All right. So with that, substance use is prevalent, but can be better identified in medical settings using validated screening instruments. Universal alcohol and substance use screening is recommended for everybody aged over 18 by the United States Preventative Task Force. Simple screeners can be implemented or more robust ones, just depending on your clinical workflow. And there are resources out there, of course, us as a resource too, if you have questions about how you can implement screening into your clinical setting. Thanks.